that Deuterium, the compound?
Is that 177? What is that?
Is that what?
Deuterium on number 21. What is it?
Deuterium 90?
90?
Is for
It says numbers after.
it's for Vinorabin. It's not most
21.
YTTRIUM 90.
90. But the number 21 in the parentheses. The
177.
Okay, thank you.
What are you changing?
They took my seat, so I have to sit somewhere else.
Just tell them
I
to
don't
get
like it.
Don't say move. Tell them to get up.
I'm a lover, not a fight, Dr. Mo.
Yes, thank you. Thank you.
So the parking.
I bought it on 54th Street in
Stop.
Chicago.
So there was issues with the parking garage, so people may be trickling into it.
Oh,
Yeah.
so we'll give them 2 minutes.
Yeah, 2 minutes is a lot, Drew. Last time I caught it, girl, before it went dark in this place. Look at your phone. Look at your phone. It went all the way down.
I have some. All right. 8 o'clock. past it. Let's get started. There's a relatively new modality for treating breast cancer. It's where you conjugate a HER inhibitor with an anti-cancer drug from a different class, and it's just called monoclonal antibody drug conjugate. So you can say it as ADC, antibody, drug conjugate. I gave some examples 2 years ago, but the drugs didn't come out. I gave some examples last year. One came out on the market. So I figured, okay, that group is not going to work not too long. So that's why I left that group out of our breast cancer discussion. And then they just announced FDA approval for one of them. This month, basically. So I said, okay, we'll just mention them, and hopefully they will be a major part of breast cancer treatment. So ADC, these are the 3 drugs that are on the horizon, and HER2 was the one that FDA just approved. All right, so there'll be no question on the exam this year for your ADC. So I just brought them up just for information purposes. So they're antibody drug conjugates. And it's usually, like I said, trastuzumab, for instance. Trastuzumab is contained in that and HER2, and it is also contained in the Kadcyla. Trodelvy contains sacituzumab. Okay, so that's what is in Trodelvy. All right, so that's all I wanted to point out there. Now, we can continue with our prostate gland cancer. And we'll start off today with your signs and symptoms of prostate cancer. What needs to be stressed is that it is usually asymptomatic. And that's why by the time people go to the hospital, it's already at stage 3, stage 4, and so on. So usually asymptomatic for a long time. And it's a very slow growing tumor. Okay. But when it has metastasized, we know it can go to the bones and stuff, and liver and lungs. You do get different sets of signs and symptoms. The ones I have listed down here are the signs and symptoms that are related to metastasis. And the ones I have up here are the ones that are related to non-metastatic signs and symptoms. So before it spreads, you can see the symptoms. You have an initial difficulty in initiating a stream, that is even just forming urine. And that difficulty results or leads to a slowness of the flow of urine. So they have a difficulty in forming urine, and then the urine does not even come out. If it comes out, it will be just like little drips. And then it would be dribbling, so very slow rate of urinary excretion. And then it can form like two streams. That's what we call bifurcation. You know, it forms like two streams as you go on. And it is usually accompanied by an incomplete sense of evacuation. The patient just does not feel it. I mean, they always feel like there's something left in the bladder. You know, incomplete sense of evacuation. And then the fawn begins, the fawn that you don't enjoy, frequency of urination, and then urgency, F-U-N, and nocturia. You know, they wake up many times at night to go and urinate. And they get to the toilet and it doesn't come out. They have to strain and stay there for a long time. Okay, so now the following are the ones that are related to metastasis. You know, and if this happen, then you are really at a higher stage of the disease. Low back pain. That is because the spine is affected, particularly at the lower end. And weakness of the extremities, and that can lead to paralysis. So it can be serious, it can lead to paralysis. And then impotence, and the erection is less firm. It's not, you know, very firm erection. Loss of bowel control, loss of bladder control, and so they will not be able to control urination and defecation. They will not be able to control those, and then blood can come out in the urine. And for most men, that is what will first send them to the hospital. Men don't like to see blood in the urine, period. So that's when they think it's an emergency. They run to the hospital at that time, but it has really advanced by the time it gets to that. And then anemia and weakness, you know, and then weight loss. So all of those are the signs and symptoms of your prostate cancer. You have the ones associated with metastasis, and you have those that are prior to metastasis. That's how we divide them up. Okay. So in terms of diagnosis, so for diagnosis, of course, you have the DRE, that's the digital rectal examination. And I always say that's the only time you should allow anybody to give you the finger. So they go to the rectum and check the size of growing there. Okay. And two, we've mentioned PSA, And remember, PSA is not definitive, because there are other situations or conditions in which your PSA can go up. And the number that we give, all these 4 to 6 and this and that, for PSA, it doesn't matter much. I've seen people with PSAs of 25, and they're still walking around, with nothing happening. So it's really not definitive, but if it's high, it tells you go and get checked up. And then you have the SAP, that's the alkaline phosphatase, serum alkaline phosphatase. That should be in the range of 30 to about 130 international units per mil. So if it goes above 130, then there's a problem. And one should go and get checked up. And then you can use the ultrasound. Okay. The transrectal ultrasound, or what we call TRUS, T-R-U-S, transrectal ultrasound, that can give the physician an idea of how large the tumor is and if it has spread to neighboring, areas of the body. So you usually see it as TRUS, transrectal ultrasound. So that can be used. And then you have the bone scan. So these are the ones that are performed to check if there's metastasis, if it has gone to the bones. And you can also see your liver function test being administered, to see if it has gone to the liver, liver function test. And then radiography, and it will be chest radiograph that will be performed, and that's to see if it has gone to the lungs. And then finally, to confirm everything, one would have to do a biopsy. So that's what's used for diagnosis. And then we have treatment. And in terms of treatment, you have some non-drug treatments or modalities that you use. One.
Dr. Mo, for SAP, the
For which one?
SAP, S stands for, I know alkaline phosphatase, but S stands for what?
The what?
Say what is that?
Serum.
Serum alkaline phosphatase. Yeah. Okay, so some non-drug modalities. Of course, one can use opiectomy. So you just take out the testis, and that is part of what is called hormonal management of prostate cancer. For the have ochiectomy, which is like a surgical means. And then you have the manipulation of androgens. Because the way your prostate cancer grows, I mean, you have testosterone, and testosterone is converted to dihydrotestosterone. Okay? And that's where your 5-alpha reductase comes in. Right here. 5-alpha reductase will convert your testosterone to dihydrotestosterone. And it is the dihydrotestosterone that actually increases cellular growth of the prostate. Okay. So even though we have the group here somewhere, number 28, okay, the 5-alpha reductase inhibitors are really not very good for treating prostate cancer. They are good for treating BPH, benign prostatic hyperplasia, but they are not very good for treating prostate cancer. You can use them, prophylactically. They can help to reduce the incidence of prostate cancer by about 25%. But if the prostate cancer is already established, 5-alpha reductase inhibitors can actually worsen the incidence of that prostate cancer. They can make it more virulent, that is more aggressive. So, but anyway, so non-drug therapy, we talked about epiectomy, and about the manipulation, hormonal manipulation, using androgens manipulation. We can either inhibit androgens synthesis, you can inhibit synthesis, or you can bind to the receptor and inhibit function. Okay, so that's how you do hormonal manipulation. Okay. Another thing that one can do is to resect the prostate. Okay. So you can go through the urethra. So it's a transurethral system. Resection. Of the prostate. So that's another one, and that's the one that modality is the one that is usually referred to as TURP, transurethral resection.
Are they doing this for BHP or not?
What?
For the benign one, are they?
We're not talking about BPH at all. We just mentioned BPH when we mentioned our 5-alpha reductase. Our discussion is prostate cancer. Okay. So, transurethral resection of the prostate. That's how you get the TURP. So that can be used. And then you can have an ablation after freezing. So you freeze the tissue and then you ablate. That is called cryoablation. See, anything cryo means freeze over. So cryoablation can be done. And one can use, I would say, supplements, yes, and diet or food, which would include nuts and stuff. So we know that we mentioned vitamin E before. We know that selenium can also help onions, can also help pumpkin seeds. And also help almonds, can help salmon, all of those can help in terms of
Garlic?
we mentioned garlic last time. All of those were mentioned last time. Okay. So and then finally you have radiation, because radiation would also have to be part of the non-drug. For radiation, you can use an external beam. So you can just radiate the body externally. That's when you use iodine 125. I-125 is helpful. Palladium is also helpful. Palladium that can be radiated from outside. Palladium 103. But you also have some systemic means of radiation. Strontium. Can help. That can be systemic. Radiation. Strontium 89. Strontium 89. Samarium also works. Samarium 159 can work. So these ones that are used systemically, you're looking for a radioisotope that can target the bones, the ones that can go to the bones. So that's non-drug treatment. And then we can go to the treatment. Shouldn't have rubbed that up, okay. So for the treatment, one thing that is often done is to use hormonal manipulation. And for the hormonal manipulations, you'll be talking about some gonadotropin releasing hormone inhibitors and analogs. And the gonadotropin releasing hormone analogs, those ones will cause an initial release of the hormone. So it would seem like the prostate cancer is getting worse. And then they would inhibit the production of that gonadotropin releasing hormone. The direct inhibitors, these are the ones we've given you up here, numbers 2, 3, and 4. Those ones will directly antagonize or inhibit gonadotropin releasing hormone. The relugolix, this drug here, that is the very first orally administered gonadotropin releasing hormone antagonist used in the management of prostate cancer. In fact, using it has been given a name, is androgen deprivation. Method. Therapy. Androgen deprivation therapy. That's when you use relugolix. Now, I put this number 5 in here only because of the name. Elagolix is similar to relugolix, but elagolix is not used for prostate cancer. It is used to treat endometriosis. So I just put, that's why I put the box around it. Then you have the gonadotropin releasing hormone analogs. That is the ones that will cause an initial release before blockade. Okay. And those are the ones I've listed from number 6 to number 11. And apart from luprolide, which was the very first one made in that group, you see that all the rest of them end in relin. And if you see Lou, the name Lou, L-E-U, Lou. Lou goes on boss trip, that is his boss trip. So those are the gonadotropin releasing hormone analogs. Those will cause a release before blockade. Okay. And they're part of the hormonal management of your prostate cancer. Okay, so those are for gonadotropin releasing
Dr.
hormones.
Could you please repeat once again 6 till 11? What is their purpose?
Okay. You just say, if you take that first part of the name, Lou goes on, that's your N, Lou goes on his boss trip. Right? Okay. All right. So those are ones. The number one up there, you already know. The PARP inhibitors, did those under breast cancer. I just highlighted rucaparib because that is one PARP inhibitor that can produce that same distinguishing adverse effect of capecitabine, that palmar-plantar erythrodysesthesia, okay, and foot disease. So that's why I just wrote that rucaparib there to highlight that. Okay, going further with the hormonal management, you can also use anti-androgens. Okay. And the anti-androgens, part of the hormonal management, the anti-androgens, you divide them into two groups. You have those that are steroidal in nature. So steroidal anti-androgens. The ones that are steroidal in nature will be non-competitive in terms of their pharmacological actions. And then those that are non-steroidal would be competitive inhibitors. This would be non-competitive. And so the ones that will be competitive, that is the ones that are non-steroidal, are 12, 13, and 14. Abiraterone would produce its pharmacological action by inhibiting the synthesis of your androgens, because it would inhibit 17 alpha hydroxylase. Whereas cyproterone would inhibit binding of your androgens to your ARs, that is androgen receptor sites, ARs. Okay, it can bind to your testosterone receptor site. It can bind, or that is inhibit binding of that natural substance. It can bind to the DHT site. So both testosterone site and DHT site can be blocked or inhibited by cyproterone. Okay, and you know that megestrol or Meges is a progestin, and progestins can inhibit, both androgens and estrogen receptors. So those will be working, non-competitively. Now the ones that are non-steroidal in nature are the next from 15 to 20. So those would be non-steroidal, which means they will work competitively to antagonize your progestins. So there will be a competitive inhibition of progestins at the receptor site. that's how those ones will work, which basically means, you know, if you change the amount of progestin that is coming in, the effectiveness of these drugs will be reduced. That's competition. Okay.
Dr. Moore?
Yes.
So sorry, you said your 15 to 19 are the steroidal non-competitive?
If it's steroidal, then it will be non-competitive. If it's non-competitive, that's right here. If it's steroidal, it will be non-competitive. And if it's non-steroidal, it will be competitive.
Yeah. So is it 12 to 14 that is steroidal, or is it 15 to 19 that is?
This is steroidal, 15 to 20 will be non-steroidal.
Okay, thank you.
Okay. So that's for the anti-androgens. All right. And that should be for that hormonal type things. All right, then we can quickly remove these ones. Your antifungal azoles, you're talking about like ketoconazole. If you give a very high dose of ketoconazole, and by high dose we're talking about 400 to 800 milligrams 3 times a day, that is extremely high. Because normally ketoconazole you give at what, 200 milligrams, you know, once, at most twice a day. But you're talking about 400 to 800 milligrams 3 times a day. That will go towards the inhibition. You know how the azoles work. C14 demethylase is what they will be inhibiting. This, if you remember the fungal pathway, for the humans, it will be going towards the production or synthesis of androgens. So that's how that works. It just inhibits the synthesis. MCIT is extramustin. So it's really a combination of nitrogen mustard, your alkylating agents, nitrogen mustard, and a high dose of your female hormones. Okay, so it's a combination of those two, and that combination seems to work well, but it is going down in terms of favor. People don't like to use it that much anymore. So, taxanes, because we've done, 5-alpha reductase inhibitors, you're just talking about drugs like dutasteride and finasteride, okay? Dutasteride. And you have a drug called Jalin. And Jalin is a combination of what and what? Dutasteride. And what else do you use for moving? Okay, tamsulosin. So Jalin is a combination of dutasteride and tamsulosin, which are the 2 drugs we usually see used when they're treating either BPH, mostly BPH. So, like we said, and low dose of finasteride is also used for what?
Urination? Alopecia?
Alopecia. Okay. So that's all for that. So let me leave this extramustin because we'll talk about it in a second. Taxanes, we already know those, but carboxytaxol that is the one that is most often used in prostate cancer. But anyway, so you still see your paclitaxel used, you still see your docetaxel used. And in fact, if cabazitaxel is used, it should be given concurrently with prednisone. Those four should be used in combination with prednisone. Okay. When they're used to treat prostate cancer. So that's for the taxanes. Yervoy and Opdivo, those are, well, Yervoy is ipilimumab, so it is a monoclonal antibody, ipilimumab. And it's an agent that inhibits or that interferes with the actions of CTLA-4. So cytotoxic T lymphocyte associated antigen form. And that is an agent that is ipilimumab that gives you the off switch. So in other words, it's a drug that can affect the checkpoint in the actions of your cytotoxic immune agent. So if under normal conditions, CTLA-4 prevents your T cells from recognizing a cell as an antigen. In other words, it prevents your body from attacking its own immune system. Okay. And so if you give a CTLA-4 inhibitor, it's like you're waking up your T cytotoxic cells. Okay. And so they will be able then to attack the cancer cells. Another checkpoint product, the checkpoint or the off switch product, is Opdivo. That inhibits the programmed death PD-1 protein. You know, PD-1. See, CTLA-4 and PD-1 are both checkpoint proteins. Okay, so by giving these two together, you know, Yavoy and Obdivo, you talk about a double checkpoint blockade in the treatment of prostate cancer. Orteronel is an agent that tends to inhibit the lyase activity of your cytochrome P450 17A1. See, that lyase has to be active for you to produce androgens in the body, either in the testes, in the prostate, or in your adrenal gland. You need lyase to be active. That is the CYP17A1 lyase. So if you give that drug, it can inhibit the lyase of your CP17A1, and so you will not be producing your androgens, either in the testes or prostate gland, and so on. So, Sipuleucel, that is a product that actually contains, well, sometimes we call it autologous. Cellular immunity therapy. The Sipuleucel is made by combining antigen presenting cells from the host or from that patient with the PAP, prostatic acid phosphatase. Okay. So the PAP is representing an antigen. And then you combine that with GM-CSF, which is a growth factor. And so those three, when combined together, will give you your Sipuleucel. Sipuleucel T. And what that Sipuleucel can do, one, it can increase the actions of antigen presenting cells. So you have more APC, antigen presenting cells, taking your tumor antigens to your immune system. So it increases the actions of antigen presenting cells. Then it activates T cells in that immune system. So it can activate T cells. And then number three, it can increase the conveyance or movement of the activated T cells to that prostate cancer tissue. Okay. So it can do that. And then number four, it can create memory when it activates all that T cells and stuff. It will create memory T cells so that if the new cancer cells come in, and it will be cleared up immediately. That is what is called anamnestic response. So it will attack the new antigen, which is your cancer cells, before it can do anything. All right, so Utram and Pluvicto, those are just using radioactive compounds, and they're usually combined with a monoclonal antibody, so you can have direct activation of your immune system to battle the prostate cancer. For that Pluvicto, it is using the membrane. It's called prostate-specific antigen, but on the membrane, so PSMA, prostate-specific membrane antigen. That's what that isotope, lutetium-177 will bind to. And so it will be more specific for the prostate cancer. All right.
You're right.
Oh, I don't know where they have.